Hey, care partners, welcome back to Memory Care with Teresa Youngstrom. Excited you're here. On this podcast, we really just go about trying to educate everybody on better techniques on how to come alongside and join folks on the journey who have a deteriorating brain, no matter what their diagnosis is. So, thank you for being here. Be sure and pay attention to the end. There's some good stuff. We always have a bonus page found in the show notes for you, always trying to just get more information out there. So, again, Teresa Youngstrom, my company's A Better Approach to Memory Care. Today, we're going to focus on first responders because, first responders are amazing. Amazing, amazing. I have so much respect for first responders because they tend to run into danger. Whether you're a police officer, firefighter, EMT, you guys run right into the emergency and it's amazing. It's amazing. Courageous, selfless, and like I said, I have a lot of respect. Back in the day when I worked in the emergency room for a long time, worked closely with a lot of you guys and gals, and got on a first name basis because so frequently you were bringing us so many crazy things. But I'm not going to act like I know your job, but I do want to teach you some things today. So maybe we just start off with some assessment skills and see where you are. Now, I feel bad for the people listening on Spotify. You're not going to get to see my great pictures, but you'll understand as we're going through this. So just take a look. And I just want to be able to have you look at these pictures and tell me a little bit more about what you're seeing. And then what do you guys do in a situation like this? Because I'm not about to tell you your job. I knew how to care for the patient once you brought them to us. Okay. But I can't exactly say that I know your job. Thanks, Miami Township Fire and EMS. You guys are awesome. I did my first training there for fire and EMS, and they were just amazing. And I was completely surprised that they found this information good and important and useful. And they've had me back several times. So let's get started. So today we're going to check assessment skills. So let's go to the big slide. Um, I want to know what you guys do when you see a situation like this. You drive up, this is what you're seeing. What's going on here? For the Spotify crowd, guess what? We've got a car off the side of the road on fire in the front end. So, I mean, you guys have just your routines, your algorithms, your skills. You know what to do first. And if you're like us in the ER, different people go in for different jobs so that we can secure the area, so we can put the fire out, so we can get, any potential injured people out. And but you guys know those routines like the back of your hand. You practice, 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 just like we did in the emergency room. Once you bring that person to us, okay, whether it's putting a line in, getting an airway, assessing, getting vital signs, and getting started. What's going on here? What do you think? So a guy's holding his chest, left side of his chest. Yeah, that's usually pretty straightforward what we have going on here. And again, you've got algorithms, you have procedures, you're going to check some different things. And we're going to rule out some things. When they come to us, we got to rule out that this isn't just a terrible indigestion and that there's definitely a cardiac thing going on, don't we? But time is of the essence because we both know that the sooner we implement these life-saving medications, the chances that he'll have little residual problems is just so important. And so how about this? I know you guys see a lot of this because I know when I went to work in the emergency room, it was a level 3 trauma center, full-time nights. So trust me, I should have written a book then because I saw a lot of things, and a lot of those things stick in my mind today. I probably don't get flustered as quickly as some other people because I know what real tragedy looks like and real emergencies look like and what significant bleeding looks like too. Life and death situations. Certainly was in plenty of those. But in your job as police officers, as first responders, you see a lot of dumb stuff, don't you? Well, and so did we. Honestly, if there were no drugs and alcohol, half of the patients that I saw in the emergency room and that trauma center probably wouldn't have been there. But life is life, and people do what people are going to do, and we got to be able to take care of them. And that's what we did we just gave great care. No matter who walked through the door, we were going to take care of them. Even got to deliver a baby outside an ambulance once. Just saying. I had worked high risk L&D prior to working in that ER, and there weren't a whole lot of people running to the ambulance. And I'm like, what? That's exactly what I wanted to do. That was what I was best at. So anyway, I know you guys happen on to a lot of stuff like this. Some uh-ohs, right? Not that there's technically something life threatening going on, but this one will get your blood boiling a little bit and make you one gentleman in a class said, "Drive very fast," and I said, "Yeah." So for those of you on Spotify, we have a very pregnant woman, kind of looking like she is uncomfortable. And so, like I said, for this, I worked high risk L&D. Love those patients. For some other people, this is exactly what they don't want to see happening. But you guys know the procedures, and you know what to do next. But what about this lady? What do we see going on here? I want you to look at her. Let's make the screen big. What do we want to do with this gal? And can we see what's really going on? And I've used this slide in a lot of classes um, for a lot of different groups of attendees. And I'll get, well, she's a little overweight. Okay, she's a little overweight. She's probably a grandma. Looks like she got a great grandbaby. She's got a little bald head on her lap. Yep, all those things. I've had people say, well, she looks happy. I'm like, yep, yeah, I think she looks happy. I had someone tell me her eyes are unequal. Her eyes are uneven. And I said, a lot of people's eyes are uneven. Honestly, we just don't notice that. We're not measuring people's eyeballs. But what you need to know, I want to know, can you see the dementia? Can you see the dementia? And the answer is no, straight up, no. It would surprise you to find out that she is well into her journey with dementia. And she's great with the grandkids, but don't push her buttons. I'm telling you, heads can spin. She could really startle you with how quick she becomes angered. And so we need to talk about that today, guys. What's going on here? How can you guys develop some skills to better assess people living with dementia? Because guess what? It's all around us, and we're seeing more and more of it. We are. In America, once we're past age 65, statistics show that probably 25% of the population has some symptoms of dementia, or at least what we're calling mild cognitive impairment seems to be the going word these days. But then by the time we're 85, half of the population seems to have some form of a dementia. So what are we going to do about that? And how do we prepare ourselves? And how do you develop skills? The more I talk to first responders, they tell me that the training they get for the mental health part isn't extensive. And it's usually mental health mixed in with the dementia training, mixed in, so they'll learn about schizophrenia, bipolar, and Alzheimer's in the same 45 minutes, 50 minutes. And so I need to break that down because, of course, this is what I do. And I want you guys to have better skills going into this. And I think that as I keep training more and more first responders, the aha moments are significant. And so I want you to have that aha moment so you have this tool. So, what are the classic symptoms? Real quick, memory loss. Is it short or long term? Typically short term. That's correct. Getting lost, anxiety, depression. Depression is technically treatable, but we definitely see a lot of mixed picture with people who have dementias. All right, hallucinations. What do we do with hallucinations? Well, I frequently get called about hallucinations and what can we do for hallucinations. Actually, one happened just this week. And they said their mom will sometimes be talking to her mom and they can't see her and they want to correct her and set her straight. And I just said, hit the pause button. Is she upset? Is she crying? Is she, is there any reason why we should be upset about that? And I said, if it's something she's enjoying that conversation, let it go. Let it go. I remember walking into a woman's room. I'm been around the block and have worked a lot of different areas, but I worked in a hospice unit years ago and the night shift. Of course, I did nights a lot of years. Anyway, and I heard voices in this one room. It's about 2 o'clock in the morning, right? Not sure there should be many voices. And I knock on the door and open the door and I said, Mary, are you okay? And she said, "Well, honey, can you see who's here?" And she proceeded to introduce me to 3 people that she felt like were visiting. And I said, "Oh my goodness, how wonderful." She said, "Well, you can come in and stay and visit." And I said, "I didn't mean to interrupt. I'm so sorry. I was just checking to make sure you're okay because I like to do rounds frequently doing night shift, right? Because you can head off a lot of problems if you catch it early, right? Before they've destroyed their room because they don't know where they are and they want to go home. And so I just closed the door and let her have her visit. Can we do that? Is it okay? Frequently people want to call the doctor and they're not going to have much for you except more medication. And I just always want to say, wow, will it make her think more clearly? Is it going to make her transfer more safely? Are we asking for a fall at that point? If we make her more confused or more hypotensive or whatever that might be, that she's going to pass out and fall and break the hip and then die. You guys know that's the normal progression. And, so I wanna avoid that at all costs. So hallucinations, not a real big deal for me. Now, if it's something that has them ticked off, well, then I'm gonna go in there and say, "Are you kidding me?" And I'm gonna validate that. "These kids are bothering you? Well, I'm not putting up with that at all. Kids, you get out of here. Did you see grandma? She is not happy about you being, in here. Now give her some respect and get the heck out of here. I'm so sorry, grandma. That shouldn't happen. You know what? I'm glad you told me. Hey, you know what? I was thinking of maybe making some, biscuits today, and you know what? You are the best biscuit maker I know. I was hoping you could coach me on it. Could you come help? And you see how I was able to affirm her issue, do something about it to de-escalate the energy, and then redirect it by needing her help. Because typically, guys, if they get a good mad going on, you gotta validate it, de-escalate it before we can move them physically or emotionally to another place. We leave them in that same spot, and guess what? They're going to get that mad again and again and again. And if you come in correcting and finger wagging and tell them to straighten up, we don't act like that. That's not happening. That's all in your broken brain. Oh, gosh. You know what? If their brain is really broken, you may have a big fight on your hands. And who caused that? We did. Who gets medicated? Yeah, they do. See, I'm going to get on my soapbox about that. I think we need to just learn better techniques and how to come alongside. And so, if you guys are called out for hallucinations, all right, listen to the stories, and maybe we give them some better techniques, but maybe they need to talk to someone who counsels families on dementia care and how to come alongside and even accept and agree when those things are happening. All right. And maybe we check the medication because sometimes the hallucinations from a medication they're already on and not necessarily from the brain failure that's going on. So let's move on. Unable to follow instructions. We see that, sequencing things can become trouble. Increased confusion as the evening hours, we call that sundowning, and I've researched it. It's really tired brain. But you know what? It's life. Are you guys as good at 10 PM as you are at 10 AM? I'm not. I'm not, and so you're being inconvenienced about something at 10 PM. You're not going to be as sharp or as kind in a lot of cases as you would be during regular business hours. That's normal. But yet we beat these people up. But with the dementia, it certainly can make them more confused. So I would just say those night shift nurses and aides, they've got their work cut out for them and they need more patience. And they need to be able to, again, validate their position, accept and agree. Oh, you need to go home. Well, you know what? Let me get a piece of paper. We're going to write down what we should take with us because you've got a few things here. But yeah, okay, we can figure this out. I'm so glad you told me. That's a whole different scenario than, Bob, I've told you 3 times this is your home. Now sit down and it's time for bed. All right? I've told you already. Why can't you remember? Ah, stop it. Stop it. Please, please, please. This is a broken brain. They don't act this way because they want to give you a hard time. They're acting this way because it's the best they can do. It's what they have left. It's the best they can do. We're the ones who have to change the way we do things. We cannot correct and finger wag and get them to understand. There's no logic. So what are you doing all that explaining for? Don't expect them to hold on to it if their short term's already damaged. Okay. Declining social skills. We see that defensive, never wrong, paranoid, and suspicious. We're going to talk more about those characteristics because what I've learned is that some people who develop dementias early on, they may have an awareness this is happening, but it can transition. It can transition to a place where they seem to be unable, they're in denial. They're just in denial that this is happening. And, I'll get families that'll say to me, you know what, she's just in denial. She knows it. She knows she has this, but she's just in denial. She's being stubborn. We need to give her something. Okay, time out. Did you know some people have awareness as their brain declines? And they're typically sad, they're typically, clingy, more depressed, "Honey, I'm not anymore, honey, don't leave me, I'm not, I just can't. I don't know anymore, honey, I just don't know, I'm so scared." But then you have some on the other end of the spectrum. They no longer see the disease. It may just start off appearing during sundowning or when they're more tired, but for about 50% of people who have a legitimate dementia, brain failure, about 50% of them will develop something called anosognosia. We're going to talk about that, where they do not have awareness of the disease and they operate from that position. And I want to train you all up on what to do with those folks because they tend to be the more cantankerous, more difficult, more argumentative. They seem to get themselves in hot water. They are the ones that you all get called out about. And they're the ones I get called about too. We'll talk about that. So, wandering, trouble sleeping, unable to follow the conversation. So, keep your words to a minimum, right? Lack the initiative for hygiene. We definitely see that. Unorganized with bills and mail. They can be impulsive and definitely have trouble following through. But it's brain failure. It's legitimately brain failure. Their brain will be smaller than yours and mine. Okay. If we don't get this. But by the time we see symptoms, it's been going on for a while. Some 5, 10 years. Now they're thinking maybe even longer, but at least 5, 10 years. And their brain, we're going to, if you do MRIs and progressive MRIs or PET scans, there's even new scans coming out, we can see the decline in the brain. We can see more space and less neurons, less brain cells. Okay. I mentioned this anosognosia thing, and it's so, so vital you understand this. If you don't pick up anything else that I say today, this is what I want you to get. Okay, here on slide 15, I want you to have this. Anosognosia is the inability to see your brain deficit. Hmm. Well, you might have seen that with someone that has bipolar disorder, but you didn't know what it was called. Because as an old nurse, how come I didn't get trained on this? Kind of ticked about that. But thankfully, I know about it now, thanks to Teepa Snow and Positive Approach to Care out of North Carolina, internationally known. She's amazing. I went to train under her because I needed to find someone who knew, who understood this better than anybody else I could find. And she was the one. She told me about anosognosia. So you probably know someone who has bipolar disorder. Well, what do you know about bipolar? Well, they need medication, and until they get on some medication, life is very difficult. But once we get them on the right dose, the right medicine, they can function at a very high level, and it's so good. But what happens typically with people with bipolar disorder, once they've been on their medicine for a while, they're feeling great. Really? You saw that too? Yeah, they stopped taking their medicine. Why? Because they're healed? I heard the same story. Do we know the same person? No, it's a very common thing that we see. Yeah, they stopped taking their medicine because they're not sick anymore. It's been a miracle. Okay. Well, what we know about anosognosia, it's an additional diagnosis and it seems to affect people with bipolar, schizophrenia, and dementia, and probably more, but that's what I focus on because that's where I teach. And so, unless someone with bipolar has an accountability partner that's going to have them continue to take their medicine on a regular basis, guess what? Their life will be a roller coaster of challenges, a roller coaster. But they aren't stupid. They're not ignorant. It isn't that a miracle couldn't happen because they could. But I'm just telling you that usually it's anosognosia. They can't see their brain failure, they can't see their disease. So the same thing happens with people with dementias. So you go out to see this person and they're paranoid and suspicious. Nobody does a blankety blank thing around here. I've had to, and they might be sitting in a wheelchair telling you they've had to wash the windows and clean the closets. And nobody does a blankety blank thing around here. And, you're being abused. And you're thinking, doesn't look like quite the story. But I want you to hit the pause button and just step back and evaluate what's really going on here because that's what this looks like. Anosognosia, it's when they honestly do not see their disease. They think they're smarter than anybody else in the room. Now, typically, you guys in uniform with badges, typically people my age and above have a great respect for you guys. And so the nice thing is you get out there and hopefully they are respectful of you because you are wearing that uniform. But what you need to know is that these people that have the inability to see their brain deficit, they can be very difficult, guys, because they think they're always right. They're never wrong, but they're always the victim. They're demanding. Um, and in my mom's case, who had anosognosia, you could come in and offer to help take her to the bathroom, and she was in a wheelchair. And she would put her hands on her hips and just say, "Excuse me, but I do that myself," with attitude. And so it's like, okay, what are we going to do to come alongside and serve this person? What are you guys going to do to come alongside and assess that person and be part of the solution with them and not part of the problem? Because the last thing we need to do is finger wag them and think that you can do a whole lot of explaining and they're going to finally have an aha moment and say, "Well, thank you, sir. Thank you, officer, for explaining that I'm the problem here and I have an attitude and obviously my brain's broken." None of that works, just so you know. These people end up getting arrested. They because they honestly, they're difficult. They're paranoid, suspicious, and they may be the one calling you constantly on the phone because they're paranoid and suspicious. But they need lots of extra care, and people need skills to work with them. You know what works? Being able to ask them for help. Being able to ask them for help. In my mom's case, it would we'd visit for a minute, very calm. We don't rush these people, don't rush somebody with dementia. The dukes are gonna come up, and boy, have you created a mess. But you could say, I would just tell her that I needed a Band-Aid, that these shoes are cute, but wow, I've got a blister and I really need a Band-Aid. I think they're in in your bathroom, mama. And she'd say, "Well, honey, take me back there." What do you know? But if I'd have said, "Can I help take you to the bathroom?" No way, Jose. No way. Heels would be digging, and she would not because she didn't understand that she needed help with that. But she did think she was smarter than me. And so we give it to her. We allow her to have that. We allow her to think she's smarter than us, and we just have to turn it around and ask them to help us. Okay? Let's go back to the next slide. So, better ways to communicate when you recognize anosognosia, or maybe you've already been out to see this person several times. You fire EMS, police officers. I know these are your frequent flyers. They are, but maybe you could send the family to me and I can train them up on how to learn to keep the peace so they quit correcting these folks. I mean, listen, I have families who get destroyed by this disease because the person with the dementia can become so difficult that they tell family members they never want to see them again. You see, it's all about the relationship. And you guys have an advantage because coming in, A, you're a stranger, and with the right side of their brain, they tend to be more cordial to a stranger. They're hardest on the people closest to them, kind of a bullseye on their back. Sorry, filters are out for the people closest to them, but they tend to be kind and more cordial to a stranger. So when you guys come out, and the uniform does help you. Um, but what we need to recognize is that they don't see their deficit. They don't see it. And so no amount of finger wagging or correcting is going to help. The relationship's what's so important. So it would be better for you guys to come in and say, "Oh, well, I'm glad you told us. It's very important, and we're going to see what we can do to fix that for you." You shouldn't have to put up with that. For example, I walked in on my mom one day and she had a good mad going on. And she did tell me she had cleaned the closets and washed the windows. And nobody does a blankety blank thing in that house. Okay. So she was using her emergency words, which usually are cuss words, racial slur, sexual innuendo. They're the words that they use when they can't use language. They can't get to their own words. And typically it means pain, fear, anxiety. What did I say? Typically, when they're shouting words of, just cuss words, and they're just repeating them, they're at a place in the disease where they cannot get to their words anymore, but they have emergency words. You're hearing them. Think about pain, fear, anxiety. It can be a variety of different things. It can be a migraine. It can be a stroke going on. It can be ingrown toenails. I had a lady with 10 ingrown toenails. The family was so done with her. So I went to see her. She had 10 ingrown toenails, guys, underneath these giant, oversized men's tennis shoes. I mean, that caught my eye when I first went out to see her. And you have those assessment skills too. You're looking at all these things just like I am as the old nurse. And I noticed that right away about her. And I thought, I got to find out what's under those shoes. Well, what do you know? How many of you can live with one ingrown toenail, much less 10? All right. So pain, fear, anxiety can frequently drive these people to the point where they're so upset that they need emergency services. That's why they're calling you. Another thing that I saw working in the ER a long time was that by the time we send these individuals to the hospital, the appendix is ruptured, the gallbladder, they're septic, but they've been complaining, but we've been giving them antipsychotics to get them to calm down. They're getting Haldol at the nursing home, but because they're fussing and they're acting out. Well, do you know with dementia, parts of your brain can be broken to the point where you can be having an appendix, ruptured appendix, and you can't even point to your right lower quadrant. Right. Think how crazy that is. I mean, because you guys, you would have been complaining when it was a 2 out of 10. I would too. But people with an advanced dementia, they can't use their hands to point to where the pain is, but they may just be shouting some cuss words. So can you be a good detective and not a judge? Are we going to just manhandle them, strap them down, cuff them, or are we going to take a minute? I mean, I know if they have a weapon, whole nother story. I'm not even going to go there. You guys have to protect yourselves. I get it. Whole nother story. But you know what? There's no weapon. This is a frequent flyer. How can you develop a relationship with them? How can you always approach from the front? You know that these folks lose peripheral vision. What? Yes, they don't have peripheral vision. Imagine at least that they have a scuba mask on. Why don't you start approaching everyone that's my age and above as if they have a scuba mask on? How are you going to approach them? That's it, from the front. Because you startle somebody that has dementia, dukes are coming up. That limbic system in their brain, that fight, fright, freeze, um, that's very active. That amygdala gets fired up, the cortisol is flying. When that lady with the ingrown toenails, she had fought with her kids so long that that's why they finally sent me out there and said, "We can't do anything with her. She's mean as a snake." And when I knocked on the door, she flung the door open. She was in this stage right here. They had worked her up where I bet she hardly ever put her fist down. She was in defense mode and she said, "Get out of my goddamn house. I'm a millionaire and I don't need you." Okay. Normally I don't cuss on my podcast, but you need to know when you hear that, there's something else going on here, all right? Because she certainly wasn't a millionaire. She lived in a nice part of town. Hair was crazy, batty hattie from Cincinnati. She had several layers of clothes on. These people are cold all the time. And we got these oversized men's tennis shoes on. Now I approached from the front. I didn't touch her. I didn't move in too fast. Showed her an empty hand. "Hey, Margaret." I don't remember what her name was. It's been so long. "Margaret, Teresa the nurse. So great to meet you." And I just waited because their vision might be poor. They may or may not have decent glasses or their own glasses on if you're in the nursing home. You know what? Their hearing may or not be great. And they're using everything they have to kind of give you the once over and see if you are friend or foe. And your tone and body language needs to be saying you are going to be helpful in this situation, but you can only approach from the front. I'm telling you what, guys and gals, if you'll take 60, 90 seconds to let this person kind of assess the situation, and you've got your hand out there and maybe you introduce it again. I finally just said to her, "Can I come in?" Very gently, and she said, "Oh, okay." Because I gave her time to assess that I wasn't dangerous. I was gonna be okay, and I came in and I was able to assess her and figure out what was causing her to be so aggressive. Now most I'm just sad to say that you probably a whole different scenario of how that maybe has worked out for you in the past. I saw a lot of bad stuff working in that ER at night. I saw a lot of people thrown down, on a stretcher, handcuffed, and, howled all through the jeans. I saw a lot of crazy things when we didn't understand what was going on. Sometimes, danger was present. We have to subdue somebody. But I'm just saying, frequently now, the first line of defense, you guys get called out to a nursing home because someone's acting out and maybe there's a broken lamp or a broken chair. And can you come in? When I teach a class, a whole class on this, and I've got you guys in a classroom, guys and gals, I want you to send one person in, especially if you're fire and EMS, because I know there's a bunch of you and you got all your equipment. But can we just send one person in without all the equipment and just one person to come in and say, "George, are you even okay? Oh my gosh, what are they doing to you here? Are you okay?" And get on his team. Can you get on his or her team with sincerity? I mean, chances are you might be able to walk them back into their bed and get them to lay down. Now, I know if they're bleeding, we got to take them to the hospital. I get it. But can we take our time? Because honestly, you guys come in, if they're already worked up, their amygdala's fired up and it's the dukes are up, and you come in, sorry to say, but like a herd of buffalo, just saying I've been there, and with all the people and all the equipment plus all the gawkers, right? It doesn't help the situation. But I've had great success sending one person in, whoever's the best at dealing with dementia, send one person in, no equipment, bare hands. Hey, George, what's going on here, man? Are you even okay? And get on his team right away and let him think he's right. Are they hurting you? And then you sidle yourself around until you're facing the same way he is against all those people. And you tell those people to get out. This is not a circus. All of you out of here. George, let me get you a chair, buddy. Are you even okay? My gosh, you've had a hard night. It isn't the time to chastise George. It isn't the time to tell him, buddy, you can't act like this. It isn't the time. It's a time to tend to his wounds. Yeah, if he's got, if he's bleeding somewhere, he's injured, he's fallen, but it isn't the time for us to be correcting and, questioning. Guess what? Lots of questions doesn't work. Basically, you introduce yourself and you're trying to assess if they're okay. You need to be part of the solution and be a great detective, and use a lot of either ors. Mark my words, you use yes, no questions, they will say no, especially in the heat of the moment. But try some yes, no questions and see if you can I get you a chair or sit on the bed? Right? Both of them are good answers. If they were bleeding, I actually went out on a run with some guys once, and they said, "This one is gonna be yours." And, I was able to talk to her, and, she needed to go to the hospital, and I was able to tell her, because I was there, I can help her to the stretcher, and I can help her sit gently on the stretcher. I don't know, we had bonded over that 5 minutes that I spent with her, and she did go with me and sit on the stretcher, and we were able to take her in without any fight, without any drugs, without any handcuffs, okay? Now, I know it's not always like that, but I'm just saying that we need to think twice about people living with dementia. I want you to understand they do not have peripheral vision. Think of it like a scuba mask. We always approach from the front. Let me go back to one slide and we'll wrap up here. I see what the time is. There we go. Let's make that slide big, slide 17. So just to review, I want you to approach from the front always, okay? Imagine I'm wearing a scuba mask. Don't rush, use fewer words, right? They rarely have the ability to use logic. So don't start explaining why they can't be outside in the wintertime at 2 in the morning. If anything, you might say, I need your help inside here, and see if you can get them to come back inside because you need their help. If they have anosognosia, guys, if they're already paranoid suspicious, they think they're the smartest one in the room. You asking for their help is a key way to get them to come alongside and join you on that, okay? Extend your hand. Let them know they have the right. Um, they have the right to be mad and tell them this should not have happened. Get on their team. Demonstrate your ability to help them get their way, even when they're wrong. Even when they're wrong, let them feel like they're right. This shouldn't happen. This, I'm gonna talk to the charge nurse about this. This should not happen. In the meantime, sit down in this bed and let me get you comfortable. See if you're safe. Or if they're screaming, they got to go home. I got to go home. Okay, yeah. You know what? I can see you got to go home. Absolutely. Let's sit down with a piece of paper and I want to write down what we need to take with us because you got some stuff here and you need to take it with you. All right. And always thank them for their help. Um, so we'll have to stop there. But, I just want you to consider, do they have hearing loss? Maybe it's not dementia. Do they have hearing loss? Do they have poor vision? Do they have thyroid disease? Do they have a urinary tract infection? I know you guys transport a lot of that, and you got to mark it down as a, mental status change and rule out CVA. But when you bring them to us, guess what? We were dipping that urine right away, and 50% of the time turned out to be a UTI. So anyway, I just want to say you guys are amazing. First responders are amazing. I have all the respect in the world, but dementia is confusing and literally, and there are better ways to go about it. And so I would love to be of more help. I'm putting together training videos that you should be able to download and stream. They're not ready yet, but they will be on the website next year. A better approach to memory care, because I want you to have great training, not just 45 minutes on mental health and dementia. There's so much more to it. I was an old nurse and I needed more training. Okay? Thanks so much for your time. Be sure and go to the show notes to get the bonus page. Thank you, Griffo Productions, for being such a great broadcaster. And again, you guys, you got this.